Hello, hello, my friends. Let's see, we're now live. Yes. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, April 14th, 2024, and it is time for another live support group meeting. Wasn't quite sure I was going to be able to do it today because I kind of, I think my body is now, dealing with the stress of what I've gone through the last couple of weeks with my surgery. But I'm here. I've got some things that I want to talk about, and we'll just let it fly. Let's just see what happens. So, I am the founder of the Interstitial Cystitis Network. I'm also the longest serving IC support group leader here in the United States. At 30 years, I'll be 31 years in September. How crazy is that? My purpose in doing these meetings is to make you so strong, so knowledgeable, hi gay, so informed and so educated that you can work more effectively with your doctors, and more importantly, that you're not going to let people minimize you or dismiss you or tell you that it's all in your head. Whoa, I forgot to put my sign up on the back. One sec, let me get it. There you go. That way you won't see my messy shelves. Hi, Ann says, can you get flares from overactive bladder? Of course you can, because overactive bladder is being driven by nerves. Of course, nerves can be irritated by caffeine and things like that. Think about it. When you drink coffee and or soda in the morning, what happens? The caffeine stimulates the nerves, and that's why many people will often go to the bathroom more. So of course you can get flares. So my goal again in doing these meetings is to get your knowledge level up, give you some new ideas, some new thoughts, some new approaches to working with doctors who are a little bit recalcitrant, a little bit of doctors who might minimize you or tell you it's all in your head. For example, let me give you an example. I have a new primary care provider who is very, very busy. I am lucky to get an email 3 to 4 days after I send a post, and thus explaining why I had 3 trips to the ER before they figured out what was wrong with me a month ago. And I have very, very consistently used Flexeril for many, many years for when I get very, very tight muscles. I have a 10 milligram pill that I cut into quarters. And I might take that 3 or 4 times a week at night before I go to bed because I'm dealing with this crazy neck pain, also pelvic floor spasms, things like that. And very, very interestingly, my new doctor reduced the dose from 10 milligrams to 5 milligrams, which means I'm only going to get 2 nights out of 1 pill. And she gave me half of the number of pills that I've normally gotten for years. Now, I might make a prescription of 30 pills last for 4 months. Nobody could ever accuse me of being a drug abuser in any way, shape, or form. But hello, I am 63 years old. Yes, I have very, very tight muscles, and there are times when it is hard to sleep if I don't have muscles. So she and I are going to have a little bit of a sit down. We're going to have to talk about this because this is not okay. So, and I don't know about you, but like I was talking to my best friend earlier today, and she's like really struggling right now. Things are hard. Feels like things are hard in the world right now. Things are very, very hard in our lives. So maybe we can lift each other up, shall we? It would be nice to do that. So, normally when I do these meetings, I do a little 30-minute intro, and then I take your questions. You're welcome to ask questions anytime you like. We're live streaming right now on YouTube and Facebook. So when I'm looking here, I'm looking at Facebook. If I'm looking over here, I'm looking at YouTube. And hold on, YouTube, let me move your computer so I can actually see anything. There we go. There we go. So a couple of different things that I think are very, very interesting that I wanted to share with you this morning. Now, when new research comes out, it is usually published. The good research studies are published in a medical journal. And you can find all of the published medical journal papers over at pubmed.gov. It's our National Library of Medicine. And so over on the National Library of Medicine, that's where I go when I'm looking for new stories to do for my, for our magazine, new topics that I like to bring with you. Interestingly, though, there was some criticism over in one medical community about companies talking about these early studies and not putting them into context. They felt that there was a lot of misinformation going out because uh, uh, people reading about those studies, if you're hearing about a study from me, that some people are not putting them into context, and it's making it seem like, wow, we've got this really big new study come out. Look at this perfect treatment for IC. But if it is a very, very preliminary study that's only been tested on animals, we can't make that statement yet. I mean, there's a whole series of studies that have to be done that will prove that this proposed treatment is safe and effective. Because we don't want you wasting your money doing something that has not been tested correctly. We don't want you to throw your money away at people who are selling. One of the challenges that we have online, and also with certain non-medical school trained medical care providers who will often set up their office as to sell Chinese herbal medicine, or they're just selling a lot of other stuff. And before you know it, you, the newly diagnosed patient, walk out with $500 worth of supplements for which you don't even know what they do, because this is company just selling you stuff. So the whole reason that we have research is to try to validate this information, and more importantly, show that it's safe. Hello, Kayleen. Nice to see you. So, couple of very, very interesting studies coming on. First of all, we know that Elmiron, the only FDA-approved oral medication for IC, is, we've known this for several years now, that it is now linked with retinal disease, with eye disease. We do have some patients who are now legally blind that they have directly correlated or associated with the use of Elmiron. We actually have, fascinatingly, our first study on animals that show that if you give animals, and specifically mice, Elmiron for an extended period of time, that that Elmiron caused changes in their retinas and retinal function consistent with retinal injury. Post-mortem analysis, in other words, when they were done with the study, and sadly they took the lives of those mice to try to study what happened to their eyes. Post-mortem analysis revealed extensive retinal pleomorphism and polymegathism, a modest photoreceptor changes. We conclude that Pitocin treatment of mice causes slowly progressing retinal injury, et cetera, et cetera. So this is meaningful. This is very meaningful now, because now, in addition to the multiple studies which have found this in humans, now we have also proven that if you give this medication to mice, that retinas change too. Thus shooting down the theory that some people have, obviously when that study came out, the people who manufacture Elmiron and people who support Elmiron were gobsmacked by the whole thing. They were stunned by the whole thing, as we all were. And they were, quite logically trying to prove that maybe this medication didn't do this. Maybe there was some odd association between IC and eye disease, which this study now basically shoots out of the water and saying, no, if you give it to animals, the same things happens in their retinas. Okay. Now, you know what we've been talking about with Hunner's lesions and the role of viruses in triggering Hunner's lesions. We have a fascinating new study from Asia that I think you will find amazing. So this is one of the research teams that originally found the Epstein-Barr virus in some patients with IC. So this current study was aimed to investigate the urinary viral spectrum in patients with IC and the clinical efficacy of an antiviral treatment called valacyclovir. So 28 patients were prospectively enrolled for valacyclovir 500 milligrams twice a day for 4 weeks. Urine samples were collected from IC patients and 30 controls. Okay. So this I find really fascinating, that urinary Epstein-Barr virus was detected in 14.2% of IC patients, but in none of the controls. And the polyoma JC, they also call that the John Cunningham virus, also, but it's a polyoma virus. So polyoma JC and BK virus were detected in 64.3%. So polyoma JC was found in 64.3% of IC patients, and polyoma BK was found in just 2 or 7.1% patients, respectively, with similar prevalences noted in controls. No cytomegalovirus, varicella zoster virus, or herpes virus was detected in the urine samples. And the pain score in patients with IC significantly decreased after 4 weeks of treatment, and that urinary Epstein-Barr was undetectable in any sample after the valacyclovir treatment. And then they talk about changes in markers. So they believe that valacyclovir could relieve bladder pain, eliminate urinary Epstein-Barr, and reduce bladder inflammation. So why is it this is important for a number of reasons. Okay, concept number one is that there are a lot of people online telling everybody you all have bacterial infection. But remember last year, Dr. Ann Ackerman of UCLA, or of USC, who is the foremost biome specialist in the United States, she looked at the urinary biome and found no unusual pathogenic bacteria, but she did find one lactobacillus that was potentially bad. But the important point about her study, because this is a lady who in all likelihood could win a Nobel Prize in her career. She's so freaking good at what she does. So she found no suspicious bacteria other than Lactobacillus iners in IC patients. But so many of you believe you have infection. So what could that infection be? Well, it was our own National Institutes of Health who found, again, now that we have next generation DNA urine testing, and now that we know urine is not sterile, and now we have a way of looking at what is living in urine and what is supposed to be there, next generation DNA urine testing has opened up this wide area of new study. And that's what Dr. Ann Ackerman does. Okay, any case. So what our own MAP Research Network through our National Institutes of Health found is that some of you with really, really bad bladder pain could have a candida infection inside your bladder. If you flare after you eat sugar or a lot of carbs, or if you've been on antibiotics for a long period of time, then this is something that we can rule out with next generation DNA urine testing. But the other big thing is, again, we had researchers about 5, 6, 7 years ago who were looking at the urine of patients with Hunner's lesions versus the urine of patients without Hunner's lesions. And what did they find? Virus. Hunner's lesions are the worst form of IC, the most difficult to treat IC. When you biopsy a lesion, there's massive, massive inflammation. A biological war is happening inside that lesion. And now that we have discovered virus in the urine of patients with Hunner's lesions, and now that we have our first studies that show that antiviral therapy actually helps reduce pain, This is going to be another big game changer in the next year. Kayleen said, what is lactobacillus again? Lactobacillus is considered good bacteria. They're the bacteria that normally inhabit your vagina and your urinary tract. They're the good bacteria that kill fungus. They remember that your biome is basically a little biological war happening where the good bacteria keep the bad bacteria in check. So lactobacillus is basically your soldiers. It's your good bacteria. There are many different species of lactobacillus. Oh gosh, there's so many of them. And there's one in particular that's really associated with a very, very good outcome. But there is one lactobacillus that is not so good. And so that has been found in some IC patients, but there's no Helicobacter pylori discovery. Everybody was looking for, for many, many years, this one bacteria that they could say caused IC, just like they found this one bacteria that causes stomach ulcers, Helicobacter pylori. And of course, when that researcher made that discovery, he was laughed at by his colleagues. And now we know it's absolutely true. Bacteria can live in the acid of the stomach. They can cause ulcers of the stomach. So now we know that more things actually live in urine, the acid of the urine, than we actually realize. Good bacteria, bad bacteria, candida, fungus, and of course, virus. So I have a hunch that our own US researchers are starting to study the use of antivirals. But it's too early to say that we have data here in the United States that supports it. But I'm very, very pleased with what I'm seeing. I hope that makes sense. So again, Epstein-Barr was detected in 14% of IC patients, but not in any of the controls. And the polyoma JC was found in 64% of the patients, and polyoma BK was found in 7.1% of the patients, but there was no herpes and no CMV. So I'm going to predict that we're going to see a lot more viral research in the coming year. I don't have access yet to the new abstracts presented. That will be presented in 2 weeks at AUA. The American Urology Association annual meeting is happening in San Antonio, first week of May. That is where all the big IC research studies are presented for discussion. They have poster sessions, they have podium sessions. Sometimes they have keynote speeches, whatever. This is where the vast majority of new ideas are presented. And you know what? Hold on a sec. Let me just look here real quick. Maybe they put them out. I mean, I'm checking every week to see when they come out. Technically, they're embargoed until the event happens, but let me just look here. Let's see if they've made them public yet. I know we've got new phenotyping. It doesn't look like it. So in a couple of weeks, we'll have a lot more research to talk about. Here, hold on. Let me look in one other spot. Nope. Okay. Now, in the same line of discussion, my friends, we have our first intravesical interferon therapy. Interferons are, I've only read up on them briefly, and I might get this wrong, but they're antivirals, but they're part of your body's normal host response when you're threatened with infection. specifically viral infection. So now we have our first interferon therapy where they're using an antiviral directly in the bladder. And the results, they compared interferon installations with hyaluronic. The interferon group had pain decreased more significantly, with 77% of patients exhibiting a 30% or higher reduction in pain. It is a randomized clinical trial. Female patients with IC could benefit from intravesical interferon therapy without serious adverse events. These results offered hope for antiviral approaches in IC, but larger multi-center studies and long-term follow-up should be considered. Okay, so I consider that pretty cool also. But then I'm a geek. Okay, last but not least, here we have a brand new study that has made a correlation between hypertension, high blood pressure, and urologic chronic pelvic pain. They basically looked at the data from 424 patients with fibro IB. Let's see, hold on a sec. Let me get this right. Data from patients, 424 patients, urologic chronic pelvic pain patients, fibro or IBS, and healthy controls were obtained from the National Institutes of Health NIDDK MAP research study. They were looking for a diagnosis of high blood pressure, current high blood pressure medication, pain severity, and urinary symptom severity. And they said the combination of a diagnosis of hypertension and the use of meds was the highest in the urologic chronic pelvic pain group. And they concluded this pattern of findings suggests that there may be a relationship between hypertension and urologic chronic pelvic pain, also known as IC. Okay. Treating hypertension among these patients may result in reduced pain and symptom severity. And they're asking for more research. Now, I emailed the lead author of this a couple weeks ago. And I said, because this comes as no surprise to me at all. Because remember, we have subtypes, or we have phenotypes. So we've got Hunter's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and widespread pain central sensitization. So I emailed him and I said, so I'm not surprised by your data. Did you look at this based upon the phenotype? And he went, no, what a good idea. And I went, well, this is why. Because it would come as absolutely no surprise that patients with widespread pain would have high blood pressure, because patients with widespread pain are in a constant state of fight or flight, which raises your blood pressure, raises your heart rate, and tightens your muscles. So anyway, it's pretty interesting because he was like, I don't think he hadn't really, I mean, this is our challenge with a lot of these basic researchers, is that they don't talk to patients and they don't associate with patients in any great detail where they can learn from us. And as an absolute basic, of course, patients with widespread pain are probably going to have high blood pressure. I'm one of them. I'm now on losartan, a very, very low dose of losartan. I'm very happy to say that my blood pressure, the last time it was checked last week, was 125 over 88, something like that. I'm like, when? I get so annoyed with all the things that can go wrong with our bodies. It's very, very frustrating. All right, here, hold on a sec. Hello, Donna. Donna says, I'm feeling very good today thanks to a pelvic floor physical therapist who specializes in dealing with nerves. I will call you soon. I can't believe how I'm feeling right now. Yes, excellent. She says, I'm feeling so hopeful. I was actually working in the yard with Mark. We both got so emotional because it has been so long since he has seen me feeling that good. Jill, there is hope for all of us. Absolutely, my dear. Absolutely. And she says, if you struggle, don't give up. Absolutely. Absolutely. All right, let's see what you guys are saying over here on Facebook. Deborah says, if you take an Elmiron, contact an attorney to see if you qualify for the class action immediately. If you need help, contact me. Exactly. Anne says, "Can you have a clean bladder and have IC?" Of course you can, Anne. Of course you can. Most of us have clean bladder. Most of us have normal bladders because for most of us, it's being driven by muscles and nerves, and the bladder is just being victimized by very tight muscles and or nerves that are very, very inflamed. Most of us have normal, healthy bladder walls. Kayleen says, "That was my last two UTIs, both before both hernia surgery and hemorrhoid banding." Okay, which one? Okay, Lisa says, "Hello, Lisa. I'm not taking D-mannose, especially after being with my husband." I think you mean I'm now taking D-mannose, especially after being with my husband. I have just started this. I'm not diabetic. Is D-mannose safe for daily use with IC? Yes, it is. As far as I know, I mean, in 30 years, it's commonly recommended for bladder patients. I personally don't know of any adverse events with D-mannose. I'm sure there might be some in patients who use a lot of it, but it doesn't sound like you're using a lot of it. I have seen a few comments about women saying they've been using this for a long time to help their IC. It has helped me a lot. So D-mannose is a simple sugar that the human body does not use. It's like fructose, glucose, sucrose, mannose. It's a sugar. But because the human body doesn't use it to any great degree, when you actually take D-mannose, most of it is excreted immediately into your urine. And what makes D-mannose kind of cool is that it has a cell receptor that matches a cell receptor on the E. coli bacteria. So if you've got E. coli swimming around in your urine and you've got D-mannose in your urine, they're going to meet and connect. And when they connect, there's no separating them. That D-mannose has hold of that bacteria, or the bacteria has hold of the D-mannose. And once that's like that, you just pee it out. And so D-mannose is, in fact, been, it's got solid studies showing success, not super, super solid, but some solid studies. It's a fairly benign first line approach to trying to prevent UTI. Not a treatment for an active UTI, but I also think, Lisa, it's very, very important that you ask yourself, why am I prone to UTI in the first place? And you have to remember that the number one reason why a woman over the age of 40 is going to get recurring UTI is because of the loss of estrogen. It's the estrogen that your bladder wall uses to produce that nice thick coating of mucus that normally pushes the bacteria away from infecting those cells. But when you lose estrogen, that mucosal barrier starts to thin. It gets thinner and thinner. Therefore, the cells are more vulnerable to being infected. And interestingly, what the research shows is that about 24 hours before the bacteria arrives in the bladder, it's usually living in the vagina. And this then led the researchers to ask, well, what's happened to our vaginal defenses? Why has the vagina become a safe haven for bacteria? And the answer goes right back to estrogen atrophy also. So normally for a woman who's had 2 infections in 6 months or 3 infections in a year, that puts you in the recurring UTI category. And in addition to giving you an antibiotic, they would normally give you a estrogen cream to use vaginally to boost your defenses in there. Because when you give these dry cells estrogen, they plump up and they start to produce mucus. So you should consider that too. Amy says my video won't load. Which video, hun? Oh, speaking of videos, guys, the master class is going up. So on YouTube right now, you've got about 13 episodes. I've got another episode queued right now that I'm going to load up tonight on oral medications. On Facebook, you guys, I gave you the first video and I gave you the link on where you can look at all of them. If you just go to icnetwork.org/masterclass/, you'll see all the videos. There's going to be 30, 40 videos in this free class because this is the future. The future is in education is through video. So I'm very excited to finally have those done. I feel like I have to apologize a little bit with how I look then. I filmed some of them literally 6 weeks after my parents died, and I kind of look at my face and go, "What were you thinking?" But I was having a good day and I just filmed. So I might not look the best, but the information is good. Deborah, listening from Mandeville, Louisiana. Hello, Deborah. Aaron, I'm feeling so much better since taking PEA. Love it, love it, love it. Anne says, went to your gynecologist. She said, clean bladder, no IC. She was awful. Well, I mean, so then your immediate question is, okay, if my bladder's clean, why am I in pain? Why am I peeing all the time? You are an anatomical mystery to be solved. It's not like you're making this up. You're literally up throughout the night peeing. Why? We had a very interesting thing happened here at the University of UC San Francisco, where the head of the department at the time didn't believe that IC was real, believed it was a mental illness, pretty much. Even though they were doing fairly significant IC research there, he poo-pooed it. So we had a patient who was diagnosed with IC back east and had a hydrodistension with a video that found Hunter's lesions, and she had the video with her, and she had very, very severe symptoms. And so she moved out here to California, ended up going to UCSF, where she saw this doctor who said, I have great news for you. You don't have IC. IC isn't real. And she's like, really? Oh, this is great. She forgot the important question that is, then why am I peeing all the time? So she called me from her car, and she said, Jill, you're not going to believe it. I don't have IC. And I was like, wait a second. Did you ask him why you're getting up all night to pee? And she goes, no, I forgot. I mean, the reason why we've had a couple of decades where doctors started to believe that IC was mental illness was because of two arrogant pricks of a doctor, urologist, who wrote a case study in the 1950s suggesting that a young woman who had the symptoms of IC had unexpressed anger manifested in the pelvis, and they believed that IC was mental illness. And so from the date of that study all the way through to about 1990, many medical schools actually suggested that IC was indeed mental illness. And it was, in fact, Dr. Dan Brickoff, who was our leading pain doctor here in the United States for many years for IC. He came out and spoke here in California at a pain conference we were doing. And he shared how he was introduced to IC when he was in medical school, because he was in internal medicine and he was a pain specialist. He said they did one day an 8-hour course on a lot of urinary conditions. And at the very end of this 8 hours, as the speaker was packing up from the podium and put his briefcase up and was gathering things, the speaker goes, oh, wait, there is one more thing I got to tell you about. It's called, and he said, these patients are going to drive you crazy. They're going to call all the time. It's called interstitial cystitis, and it's all in their heads. And that's exactly how this national doctor at that time, back in the 1980s, told this class of medical students. That's exactly what he said. And then he basically said, basically you're just going to take their bladders out. And one of the students raised their hand and said, but sir, if it's all in their heads, why would you take their bladder out? That doesn't make any sense. At which point in time, Dan said the speaker looked poleaxed and quickly packed up his stuff and left. And then apparently several years later, I don't even know who it was. He didn't even tell me who the lecturer was. He just said it was somebody who was very active in the IC world. Apparently he had a come to Jesus moment after that and started to accept that, yes, indeed, IC was real and a real pelvic pain condition. So if you have anybody tell you that IC is all in your head, just know that that's why that old study. But understand that the US government has invested well over $100 million studying IC. It is real, it is treatable, it is a pelvic pain syndrome for which there are many potential causes. And now through phenotyping, we are finding the right treatment for patients. We're no longer looking for a one treatment fits all approach. It doesn't work that way because for some people, IC begins in childhood. For others, it begins after menopause. They have the same diagnosis, but are they the same? No, they're not. For some people, IC begins after they fall and break their tailbone, like it did for me, while for others, IC begins while they go through chemotherapy. They have the same diagnosis, but are they biologically the same? No. And when you look in the bladder, that's where you really see the difference because most of us have completely normal bladders. Only 5 to 10% of patients have actually what we call Hunner's lesions. And so today we do phenotyping. We want to try to get to the underlying cause of your symptoms so that we can highlight the right treatments for you because we're long past the days of giving people Elmiron in the diet for 30 years. It doesn't work. Why? Because for most of us, we have a healthy bladder. So if you've had a hydrodistension and they've told you they found nothing, that is great news. That means you have a healthy bladder, but now we have to figure out what's happening outside of your bladder that's causing these symptoms. And that's where we're going to look at endometriosis, fibroid tumor, pelvic congestion syndrome, problems with your back, problems with your spine, problems with your pelvic floor, et cetera, et cetera. So bladder treatments didn't work for me. Why? Because I have a healthy bladder. What worked for me was pelvic floor physical therapy and things that were designed to calm my nerves down. It took 30 years to get there. Hello, Diane. Nice to see you on YouTube. Nice to see you. Kayleen said, I got gaslit really bad by this new urologist on Monday, too. Yeah. Lisa said, no hormone replacement, and I'm 50. Well, honey, there's a difference between, you have to understand why you're using it and the type of hormones that you're taking. Typical hormone replacement therapy usually involves an oral medication or a patch, the oral medication that you swallow, and it's designed to combat the severe symptoms of perimenopause and menopause. And because you're swallowing it, that estrogen is absorbed through your stomach into your bloodstream where it's sent throughout your entire body. And that is indeed a risk for some cancers. However, topical estrogen cream is not hormone replacement therapy. It is really designed to stay in the skin. It is not absorbed to any great degree to the rest of the body. So the risk of cancer is far, far, far less than swallowing an estrogen pill. So it's all about the quality and health of your skin. You know, that's the challenge here is that with aging, your skin starts to get thinner. And as it gets thinner, it becomes more vulnerable. And it's really specific to mucous membranes, your mouth, your vulva, your vagina, your urethra, and your bladder. Those are part of what we call the urogenital sinus down there. They were all came from the original cell when that little bundle of cells was creating a fetus. This one cell differentiated to create the bladder, the urethra, the vulva, and the vagina. And so they're all hormone dependent. And the bladder needs estrogen to produce mucus. If it doesn't have the estrogen, everything starts to dry out. One of the other things that happen, yeah, Diana, absolutely. One of the other things that happens, for women as they get older, and for men, bear with me, because we know you have IC too, because it's a pelvic pain syndrome. One of the fascinating things that happens, though, is as you lose this estrogen, your labia gets smaller and smaller and smaller. The lips around your vagina get smaller, and they actually kind of resorb. My inner labia are virtually gone. Fascinating. And then when you give that skin estrogen, they start to grow again. So we have to do everything that we can to keep the skin as healthy as possible. Now, some women get very, very confused because when they start that topical estrogen and the first time they use it, it burns and it burns like hell. It's bad. And you're like, oh, hell no. And you jump into the bathtub and soak and try to get it off of you. Well, it's not burning you physically. That burning sensation is a direct reflection of how dry your skin is. The more it burns, the drier your skin. It means your skin has no defenses. You're just basically putting a chemical onto nerves and onto cells. But the burning goes away. Every time you use the estrogen, that skin starts to plump up and thicken up and gets better. So you've got to ride through that first 10 days to 2 weeks of that burning. And you'll notice every time it gets better and better. Then it eventually will be like a little puff of warm air and you're gone. First time I used it, it burned for about an hour. But 2 weeks later, it burned slightly for maybe a second because my skin got healthy back quickly with that little bit of topical estrogen. And of course, there are some people who are very, very sensitive to chemicals. So I'm somebody who's very, very sensitive, and so my gynecologist at the time asked me to get a compounded preservative-free formula, which I use to this day to avoid any other chemical irritants bothering my skin. Diana here over on YouTube says, "Can you talk more about the tailbone connection to pain?" Absolutely. Let me get my model here. Hold on. Okay, so let us ponder this tailbone for a moment. So, one of the things that, and this is interesting. So, when Dr. Weiss wrote this book, Breaking Through Chronic Pelvic Pain, which again, I believe is the best book that's been written. I love, love, love this book. It's so good. He was the one who said, if muscles continue to stay tight, we have to look at bones. We have to look at bones because what puts pressure on muscles, but bones, specifically bones that are out of position. And he talked very specifically about how common tailbone injuries are in patients with a history of IC and or pelvic pain. And of course, the light bulb came on for me because my symptoms started in 7th grade, the year I broke my tailbone. It's like, okay, well, now it makes a little bit more sense. So this is what I want you to remember about your tailbone. So again, here's the back of your pelvis. Here, hold on. I got to get this right. So we've got your vertebrae. We've got your sacrum. Your sacrum are basically fused vestigial vertebrae. And everywhere you see a hole, that's where nerves come from the spinal cord and go into the pelvic cavity itself. And then at the very bottom of the sacrum is your tailbone. And so what's so interesting about the tailbone is when you look at it in animals like monkeys or like possums, any animal out there with a tailbone, you can see, with a tail, you can see that they use that tail for balance. And while our tailbone is not as long as a dog's or a cat's or as a monkey's tailbone, it moves too. It also helps us balance. It helps humans balance. And one of the ways it does that is because of all the muscles that attach to the tailbone. See this? So interestingly, for me, I broke the tip of my tailbone off completely. And it's interesting when I feel it now, my tailbone is like a little hard round knob. It's fascinating to me. So if I broke the tip of my tailbone off, then now we have a problem with stability. So some muscles were attached to the tip of my tailbone, other muscles were attached to the base of my tailbone. Every time I moved, it hurt. No wonder why, because the bone was actually fractured. One of the other issues that happens with the tailbone is that after you break it or after an injury, it loses its position. So, as an example, the tailbone, so you think about a dog or a cat that's happy and walking next to you. The tailbone is hanging down, the tail's hanging down, and the tip is curled between their back legs. That's the normal position of a tailbone, is like this, like this. But if you've broken it, it can go like this. It can stick out, or it can go to the left or right of center. So one of the most interesting tailbone patients that I worked with, I've worked with, fascinating story, and we told her story in our magazine several years ago. This is a woman who was basically bedbound. Her pain was so incredibly severe, and she'd been bedbound for some time. She watched one of these meetings, and I always said, "You're an anatomical mystery to be solved." And we went through the subtypes, and she did not have pain on bladder fill. She didn't have the bladder wall symptoms. She had very positional pain. It got worse when she sat down. It got better when she stood up, and she was having trouble finding a comfortable body position. So she started reading about pudendal neuralgia, which of course is where nerves are being squeezed by muscles and or something else. And she went to her urologist with all these symptoms that she had, and she said to the urologist, "I think I have pudendal neuralgia. I have pain when I sit down that gets better when I stand up." And she had other symptoms too. And her doctor said, "Yeah, I think you do too." So then she worked with another clinician, and I don't remember who ordered a CAT scan and or other imaging. And here's what they found. Her tailbone, instead of curving under, curved out, straight out, and it was crooked. So her tailbone was basically like this, like that. So no wonder she had pain when she sat down. The bone was sticking straight out backwards. So what was interesting is she then worked with a physical therapist and a chiropractor over a period of a year and got her tailbone back into the correct position. And what happened after she did that? Her symptoms went away. She no longer bedbound. She got out and got to work again, and she had a baby. So for all those years she'd been diagnosed with IC, doing bladder treatments, and was basically bedbound, all wasted time. Because fundamentally in the end, she had a healthy bladder. What she had instead was a catastrophic injury in her pelvis that caused very tight muscles, a very bad injury with a bone. And once they got the position of the bone corrected and they got the muscles released and relaxed, all of her symptoms went away, just like all of my symptoms went away. So that's a real story of somebody with a tailbone injury. Diane says, "I get so annoyed with all the things that go wrong with my body too. Dealing with an anal fissure now. I'm back in pelvic floor physical therapy for that. Also have high cholesterol, so I'm changing your diet. Yours is L-shaped now. Would love hearing this hopeful info. Thank you." Diana, if you pop me an email, icnetwork@mac.com, I will try to find that article. It was several years ago. And you might find it on the IC Network website, but I don't remember. It was definitely in our magazine. I'd be happy to try to find that for you. Okay. Debbie asked me, how do I feel about Eucora products? Well, Eucora is operating on the assumption that IC is bacterial in nature, and IC is not bacterial in nature for the great majority of us. Eucora certainly isn't going to do anything about fungal infections for the tiny percent of patients who have fungal issues. the great majority of us actually have muscle and nerve problems, and Eucora makes no sense. This is why we do phenotyping. We want to find the underlying cause of your symptoms so we can give you the right treatment for your unique case of symptoms. Kayleen said, was it pretty much classified as a somatic symptom disorder? No, they just flat out said it was mental illness back then. They weren't even talking about somatic symptom disorders back in the 1950s, if that's what you're talking about. Anne says, I have coccydynia. Yeah, you got a tailbone that's been injured. Lisa said, I thought your IC happened from a swimming pool. Okay, so Lisa, it was a series of events, and that's exactly what we see. So the first time I had bladder pain in my 30s absolutely happened when I swam in a swimming pool that had been overchlorinated, 100%. But the first time I had urinary symptoms of frequency urgency was in 7th grade. I couldn't sit through class. The teachers complained. They called my mom. They thought I had an infection. And I still remember being at Dr. Andrew Thusen's office, and I found in my mom's files my original medical reports from this doctor back in the early 1970s. So back then, they thought that I had a massive infection. I remember swallowing a massive amount of bacteria, but in the end, their diagnosis was that I had a very tight urethra. And so the doctor recommended urethral dilations, for which I had many. And for people who are as old as I am, doing urethral dilations was a common treatment for urinary issues back in the 60s, 70s, and 80s. They basically numb your urethra, stick a metal sound up there, and stretch it while you're gasping, because it's not a fun thing to do. Okay, so in junior high, I had frequency urgency. Then in high school, I developed severe vulvodynia. It felt like I had a yeast infection all the time, but I'd go to the doctor and there was no yeast. Then in my early 20s, after college, I developed severe IBS. Then I developed migraines. Then I discovered that I had very sensitive skin and a wicked sense of smell. That all happened in my 20s. And of course, now we know why, because that's widespread pain from that childhood injury affecting my entire central nervous system. And then, yes, the first time I had pain on bladder fill was at the age of 32 when I was swimming in a local pool and they made a massive mistake with their chemicals, and I swam and swallowed massive levels of chlorine. And that night, it felt like I had a terrible UTI. I'd go to the doctor the next day, and my diagnosis, well, actually, I called the pool the next day. Said, so was there anything weird going on with the pool yesterday? Because I swam yesterday, and the pool manager went, what? You swam? And I went, yeah. He goes, wasn't the clothes sign up? And I went, no. A bunch of us swam. He said they bombed the pool. The clothes sign was supposed to be up. So my first diagnosis for my first year of IC was actually a chemical burn, chemocystitis. IC phenotype number 2, bladder wall driven chemical irritation. But that eventually healed. What didn't heal was my very, very tight pelvic floor muscles from me breaking my tailbone. And of course, having that chemical injury and that severe pain in my bladder for the first time, of course, that made my muscles much, much, much tighter. So by the time I was 35 or 36, I was in the depths of really, really severe bladder and pelvic pain. But bladder treatments in the end didn't work for me at all. That original damage to my bladder healed fairly quickly. What never healed was my tight pelvic floor muscles. And I didn't have my first pelvic floor assessment until I was probably 45, 10 years later. So I hope that makes sense. You know, when you're the patient and you're dealing with all these random conditions, you're so confused. You're so angry and frustrated. It's like, come on, God, really? First you give me a bladder thing, then you give me a bowel thing, then you give me a vulva thing, then you give me this, then you give me that. Really? Do I have 8 separate painful conditions? Really? And there's a lot of resentment because your friends are out getting married and having babies, and you're only in the fetal position in your freaking bathroom for years as I did in my 20s because my bowel spasms were so bad back then. And you begin to internalize it. You begin to think that you're damaged goods. You begin to think that it's your fault. You begin to think that you're being punished. I mean, I was in grad school doing listen, I was a really good student. I was a straight A student. Proudly. I'm proud to say that I was a straight A student. I was a presidential fellow, actually. I was given that after I got my master's degree. But every morning I was laying in the damn fetal position in my bathroom or my bedroom. Depressed as hell. I did not understand why I had all these painful conditions. But then some very interesting things happened after I was diagnosed with IC with the bladder pain. We started looking at how nerves talk to each other. And I can remember the study specifically that proved that if you irritate the bladder, the bowel will become irritated. If you irritate the bowel, the bladder will become irritated. It's like, oh, now we're talking about nerves irritating each other. Wow, isn't that interesting? And then there was some discussion of genetics also, and that how sometimes we see this pattern in some families. And here's what I knew. I knew as a redhead that my brother is a redhead. He had very sensitive skin. My mother had very sensitive skin. My sister had a very sensitive bladder. My mother had a very sensitive bladder. So now we're looking at, the concept of inheritance and nerve sensitivity. But ultimately, in the end, the most recent research in the last 5 years now is really focusing on the concept of injury and trauma, and that for 80% of the children who develop widespread pain as an adult, there is a physical injury that happens in childhood. So for me, breaking my tailbone badly. And then for the other 20%, it's a history of bullying and abuse. When nerves, let's see, in the context of an injury, 14 days of pain will put the brain into a constant state of fight or flight. That means that the sympathetic nervous system has now taken charge entirely of your central nervous system. It raises your heart rate, it raises your blood pressure, it tightens your muscles because you're in pain and you've been in pain for a long time. The long-term legacy of that is nerves throughout the body now become sensitive. The legacy of that is widespread pain. If you've got 2 or more of the widespread pain conditions, odds are your brain is in a constant state of fight or flight, potentially from that early injury or from abuse or bullying. And the blessing here is now that we understand that, we can take all the shame away. We can take all the blame away. Nobody is saying in any way that this is mental illness. What they're saying is that it's an injury or trauma to the central nervous system. And the blessing here is once we find that patient who has widespread pain and is struggling with anxiety and catastrophic thinking, we know exactly what therapies to do to calm that central nervous system down, to get you out of fight or flight, to reduce your blood pressure, to reduce your heart rate, and to relax those muscles. So we've come so far in the last 10 years in understanding this. And now everybody accepts that for the patient who has widespread pain, we're going to be working on the central nervous system. For patients who are pelvic floor driven, we're going to be working on the muscles. For patients who are bladder centric, pain on bladder fill, if they have Hunner's lesions, we're going to have to work on that Hunner's lesion. If they have estrogen atrophy, we've got to work on that estrogen atrophy. But my testimony to you today is that bladder therapies, D-mannose, Elavil, hydroxyzine, Those did not have any beneficial effect for me other than helping me sleep. They did not address my pain. What turned off of my pain was, in fact, pelvic floor physical therapy, getting these muscles relaxed, restoring proper blood supply, reversing the long term effects of ischemia. Once we did that, everything calmed down. My symptoms went away. And if I flare, I'm going to flare from something related to my muscle. So if I have to take a long car ride, I can guarantee you that at like 90 minutes into the car ride, my pelvic floor is going to go, "Whoop." It's going to start getting a little tight, which is why I always use a heating pad when I'm driving a long distance. So why is my pelvic floor prone to tightness? Well, number one, hello, I broke my tailbone. It's still detached. The tip is still floating down there. Everything's just kind of fused together in a lump at this point in time. That's what it feels like. And I also have a funky SI joint, which is keeping the muscles on my left side of my pelvis fairly tight. So I hope that that makes sense. Hello, Andrea. Deborah said, my pain started with a tailbone injury. There you go, girl. Lori says, I broke my tailbone in high school. What does it do to irritate IC? It's the underlying cause of all of this for many patients. You break your tailbone, your muscles get super, super tight, you enter a state of ischemia, that's going to affect your bladder. Lori says, so glad you're feeling better. You look great. Girl, there's a lot of makeup happening here. If you don't, I've always felt very, very young. I have to tell you, I've always felt very young. And it isn't until this year that I've started to feel older. And I feel like my pictures show that I've aged significantly in the last 6 months. And that's just grief, you know. Betsa said, I started hormone cream occasionally. I feel like achy uterus area is tight, or the hormone cream is making me feel that. So no more estriol. Honey, you're going to have to be a little bit more specific than that. An achy uterus area. What I would ask you if you were on the phone is your pain external on your skin or internal? If it's internal, where specifically is it? Is it in your vagina? Is it in your urethra? Is it in your bladder? Is it in your rectum? Or does it feel like menstrual cramps? Does your uterus start to feel funky immediately after you start using your estrogen cream, your estriol cream? I think that that's going to be a really good discussion to have with your gynecologist. Lori said, what is the best exercise for your tight bladder? Well, we don't have tight bladders. We have tight pelvic floor muscles. And so for the pelvic floor, you want to do exercises that keep your hips level. We don't want to do Stairmaster where your hips are doing this. That's just going to tweak your pelvic floor and your tailbone. You want to stay on a treadmill. You want to do an elliptical, maybe do a rower, maybe swim. You want to stay off of a bicycle, which is going to push directly into your pelvic floor and onto your nerves. So things that keep your hips level. We have articles and videos on that over on the IC Network website with more ideas on pelvic-friendly exercises you can do. Sherry said, I'm off my Elmiron, but now I have to do pelvic therapy. Good. Because if you're pelvic floor driven, Elmiron would have done crap. Elmiron would have done nothing. Pelvic physical therapy will do everything. So that's very, very good. Kayleen says, my grandma asked me what I did that was so bad since God was punishing me. Kayleen, exactly. That's exactly how I felt when I was your age. I truly felt like I was being punished. I just didn't understand it. And, you know, now that I'm older and now that I know that it was all the result of this old tailbone injury, I mean, I fell off. My sister had a horse. I was riding the horse. I fell off the horse. You know, it is what it is. Now that I understand that sequence of events, and why I developed all these pain conditions. It has taken all the shame and all the blame away. I am not embarrassed to talk about it. I know it was not my fault in any way, shape, or form. I just got hurt. And so many of you just got hurt that we don't even, at least here in my office, we really don't think of IC as an incurable bladder disease anymore. And that's what our national guidelines say from the American Urology Association, is that there's no disease process happening in the vast majority of bladders out there. There's no disease process happening in the vast majority of bladders out there. And research, although at the last meeting that I was at, which was either the International Continence Society, I'm lecturing with them. We have 2 more meetings, or it was the AUA Guidelines Committee for Male Pelvic Pain. The number they were throwing out is that 85% of IC patients are neuromuscular in origin. That your symptoms are being caused by nerves and muscles as compared to a disease of your bladder wall. Sherry says, that's what my bladder bell giving me all kinds of it. Yeah, very true. Pelvic pain causes depression and anxiety. Yeah. Well, and Gina, so here's something else that was really, really, really interesting. So of course, anytime you're diagnosed with a painful disease and nobody can, or even if you're not diagnosed, you're trying to find the answer. Of course, depression is completely normal and logical. But we had a fascinating paper come out in the last 6 weeks that directly linked bladder wall irritation with depression. And so here's a scenario. Let's say, let me give you a really good example, because there are a lot of women out there and men out there who in their teens and 20s drink diet soda. It's all about the soda. There are some people out there who haven't had a glass of water in decades. They love their soda. But diet soda in particular is extremely irritating to the bladder because NutraSweet is broken down into very caustic, irritating substances. So imagine, and you got to remember too that our bladders were designed for life 5,000 years ago. Evolutionary adaptation is a 5,000-year process. So the bladder that we have today was really developed 5,000 years ago, back before we had caustic chemicals. So our bladder can't defend itself so well from massive, massive flows of harsh acidic chemicals. Genetics matter too. I mean, if you come from Norway like I did, we didn't have citrus. So, my bladder 5,000 years ago wasn't exposed to a lot of acids. That's very different than somebody whose ancestors were from around the equator, where they had more fruit and more acid like pineapple. Their bodies have had chances to develop defenses to higher levels of acid. Okay, so anyway, that's another fly in the ointment, so to speak. Okay, so let's just say that as a teenager, you start drinking diet soda, and you're drinking diet soda every day, all day, and you're doing it for years. Well, eventually that acid is going to make the skin irritated. And if you keep pouring acid on the wound or acid on the irritation is going to get bigger and bigger. And then eventually it's going to start turning pink, and then it's going to start turning red, and then it might actually create a wound as the acid erodes the tissue. Okay, so what this study showed is that when there is persistent bladder wall inflammation, that inflammation then spreads to the nerves, and we develop neuroinflammation. And that neuroinflammation, if it's persistent, spreads from the nerves in the bladder up to the spinal cord. And this is where the bowel becomes irritated. The bladder is the source of the irritation. I mean, the bladder has a physical injury. The nerves become very inflamed. It gets inflamed up at L4, L5 in your spinal cord. Those are the same nerves that innervate the bowel. So now the bowel is also going to start showing some signs of neuroinflammation. Well, that neuroinflammation is then going to spread up the spine. to your brain. And now we've got a neuroinflammatory process happening in the brain. And depression has been linked very specifically to neuroinflammation. So this paper made a very good case for why patients with persistent bladder wall symptoms will struggle with depression. So again, and the conclusion of the paper, okay, hold on. What did they say? They said that this is why emotional therapy is not going to provide the treatment for this type of neuroinflammatory depression. That we have to work on calming the nerves down physically, which then makes the case for some medications which can do that. So that was just like 2 weeks ago. That was right around the time I was recovering from my surgery. I know I'm going to do something in our spring magazine about. I got to start writing my spring magazine now. As a matter of fact. Lauren says, my grandpa had a small bladder capacity and frequent urination. They called him tiny tank, definitely seeing genetic correlation. So I would say, was he a redhead? Because also, you got to remember that redheads actually have 25% more nerves than the rest of you. Yes, we're blessed. Not really. It's harder to numb us for dental work. It's harder to have anesthesia. You talk to anesthesiologists, they all know that trying to anesthetize a redhead is harder. And so redheads are known for having more sensitive nerves in our bladder anyway, and throughout our body anyway. Hey, Sue. Sue's been sick all weekend with bronchitis, can't even hardly talk. Sue, get yourself checked for COVID. I hope it's not COVID, girl. We've all been there now multiple times. I still have. So I had COVID pneumonia 6 weeks ago. I had emergency surgery 4 weeks ago. And I still feel, I don't feel tightness in my chest, but I'm still not doing long walks. They said that recovery from COVID pneumonia, it takes months. So sometimes when I walk, I just feel it like right here. I did yesterday. I was not happy about that. And yet I can take a deep breath. I can absolutely take a deep breath. But it's just like there's resistance in there. Oh, it's very annoying. Damn COVID. Betsa said, internal menstrual cramps. No, I've been using that cream for a while. This appears recent, like a couple of times. I've been using the cream for 3 to 4 months. Well, Betsa, talk to your doctor about that. Maybe you're using too much. One of the things that happens, I mean, this is fascinating. You have to remember what menstruation is all about. So every month in a young woman, the uterus prepares itself to receive an egg and grow that egg and nurture that egg. And that's when the endometrium gets thicker and thicker and thicker so that it can create a placenta that will attach to that fetus and it will nurture that baby. But when the egg doesn't arrive, then we have a period, and the period sloughs off the endometrium and it goes back to being normal. And that's why we have periods for so many years. And then eventually the periods stop. But the endometrial growth doesn't always stop because your hormone levels are fluctuating and they're getting lower and lower. And so it's quite common for an older woman to get a thicker endometrium. So a normal endometrium, I think, is like two. Used to be 4. They readjusted it to 2. But if your endometrium's at 8, 10, 12, getting thicker and thicker and thicker and thicker inside there, they have to really try to understand what's happening there. Because that's where uterine cancer can grow. If it's atypical endometrial cells, atypical cells like what I had convert to cancer cells. So you can have normal endometrial cells and you can have atypical cells. And so, Beth, so I think you really need to talk to your gynecologist and let them know you're having a lot of cramping down there and see if they can try to understand why. My intention here is not to scare you. I'm not saying that that's happening with you, but we women, we have to be proactive. We've got to be aggressive and we've got to be assertive in getting the care we need and deserve. And so if you're it may be that they can change the cream you have. Instead of going from an estradiol cream, maybe they can go to an estradiol cream, or maybe they can go to an estradiol testosterone cream to try to balance things out a little bit. I think you should call your doctor and make an appointment and go have a talk with them about it. Carol said, could pulsing on the left side near the urethra be the pelvic floor? Pulses when bending and sitting? Carol! Yes, absolutely. I have the same thing, my friend. That pulsing, that vibration on the left side, that's usually tight muscles squeezing nerves. And actually, that's happening to me right now as I'm sitting here. I'm getting a little pulsing. My pulsing is like, here, hold on. So I have a small pudendal nerve entrapment, but every now and then it kicks me in the you-know-what and really starts to vibrate like mad. All right, so here is your musculature down in your pubic area, your urethra, your vagina, your rectum is down here. So my pulsing is on my left side, and actually, it's actually kind of like right here. But you can easily have a muscle that's a fluttering up there also. These are your levator ani muscles. So we would call that a pudendal neuralgia. And interestingly, as I was cleaning out stuff, I found this fabulous self-care guide for patients with pudendal neuralgia from Dr. Stanley Antelak, who's very big into this. He's retired now. And here's what he said. Let me just read this part to you. This is really helpful, by the way. Chronic pelvic, so remember, pudendal neuralgia is a phenotype of IC. These are patients who have positional symptoms. They're fine when they stand, but when they sit down, it hurts, or when they bend over, it hurts. It's driven by tight muscles squeezing nerves, okay? So what he says here, chronic pelvic pain is a boundary, quote, disease affecting urology, colorectal, gynecology, physical medicine, neurology, and other specialties. When sitting aggravates or causes the pelvic pain, and that's pain in the perineum, genitals, coccyx, rectum, or pubic hair, we suspect pudendal neuralgia, often called pudendal nerve entrapment. Pudendal neuralgia is considered in all men and women with pelvic or urogenital pain with or without bladder symptoms or sexual dysfunction. A simple definition is perineal pain aggravated by sitting, reduced by standing, and not present when lying back, and generally relieved when sitting on a toilet seat. The striking common feature in pudendal neuralgia patients is that flexion activities of the hips, like sitting, climbing, squatting, cycling, and exercises, induces or aggravates urogenital pain, chronic pelvic pain, and prostatitis-like pain. Many male patients played American football, lifted weights, or wrestled as teenagers and young adults. Often females were active in high school athletics, gymnastics, cheerleading, line dance, etc., etc. Our primary hypothesis is that hypertrophy of the muscles of the pelvic floor during the years of youthful athleticism cause elongation and posterior remodeling of the ischial spine. A medial shift of the ischial spine leads to juxtaposition of the sacrotuberous and sacrospinous ligaments that are normally quite separated. This change results in a lobster claw of two ligaments that can compress the pudendal nerve. So here's the self-care. The goal is to stop irritating the nerve. Decreasing the neurotransmitters to the spinal cord lets your pain decrease. The other secondary problems are gradually improved. This novel but remarkably effective treatment of self-care, oh, wait, hold on, I need to read. Oh, was based on the observation by French researchers who found that sitting on a toilet seat relieved pain, and by their continuing observations of exercise-induced pain. Therefore, treatment is to sit with the weight of the body supported on the ischial tuberosities, which are your butt bones, with the perineum suspended to relieve the pressure against the nerve in the crotch. And stopping the flexion activities is extremely important. So, for example, an office testing procedure, which is sitting on 2 parallel paperback books with the perineum suspended, was added to our evaluation of over 600 patients. Reduction of pain in only a few minutes can be dramatically effective in over 50% of the patients. Over a period of time, this technique can cure pain, bladder irritability, and sexual dysfunction. So what do? Do not sit. Continue all your meds, wear loose clothing that keeps pressure off your bottom, but stop all exercises except walking on a flat surface and maybe push-ups. Do not sit. If sitting is necessary, make a perineal suspension pad. And he says, use a sitting pad at work, in your car, at church. And I've got great cushions. Stand to use your computer, read the paper, do your office work. Do not sit. Lie down as much as possible to watch TV. At work, lie down on your lunch, take your breaks. And he says, do not do these: squatting, cycling, piriformis stretches, gym workouts, Stairmaster, ellipse, exercise cycle, lifting, bowling, ab crunches, leg presses, Pilates, step aerobics, yoga, skiing, sit-ups, jogging, and spinning. Avoid climbing stairs. Anyway, so let me show you the cushion. I have got several of these cushions here. This is the cushion you want. This is the cushion you want. Each butt cheek is supported, but nothing is pushing up into the crotch. And so anytime I'm having rectal pain, vulvar pain, urethral pain, this is the cushion I'm going to sit on. So the goal here is understanding that it's a biomechanical problem. Something about with the way you're sitting, or I always felt like I was just sitting on muscle and bone because I went through a period of time where I wasn't eating very much when I was first diagnosed with IC, and I basically didn't have any fat on my tush. So I really was sitting on bone and nerves. Now I have, unfortunately, more fat on my tush and more fat on my stomach. Anyway, thank you, COVID. Carol said, so Carol, pulses when bending and sitting as well as other times, absolutely pudendal neuralgia. Physical therapy is a recommended course. You need to come on over to our website and read our section on phenotype number 4, pudendal neuralgia. Physical therapy to release the nerve combined with medications that can calm the nerve, like some lidocaine cream that you can use on your skin, or Peora, P-E-A-R-A, palmitoyl ethanolamide can calm nerves, or you can go with medications like gabapentin. Sherry says, I fell off my bike. A dog knocked you down. You missed my pelvic floor, but my bowel caused a lot of problems. I'm sorry, honey. It's not quite understanding what you wrote there. If you fell off your bike, you fell off your bike. That's an injury. The question is, what was injured? Sue says, I feel people are a bit, confused. I'm not, as I am very similar in your subtypes. You talk about pool exposure, SI, salt. I don't think people fully understand why these things all affect the pelvic floor and all matter. Most of us were misdiagnosed with actual Hunner's lesions. She said it's kind of the chicken before the egg, ladies. When we were young, it was always just the egg for many of us, having multiple overlapping conditions that all need our attention. One of the events flips the switch and we are in agony and inappropriately diagnosed. Unfortunately, a lot of doctors have not caught up yet. Well said. Sue said your COVID test is negative so far. You're going to check tomorrow. Good. Christina says, through this process, I've been finding so many people saying pelvic pain is not prolapse and things. It's TMS, mind body syndrome. Have you researched that? Christina, I see subtype 5 central sensitization. Remember, IC is a pelvic pain syndrome for which there are many potential causes. So if you have Hunter's lesions, that's not mind body syndrome. That's a virus living in your bladder causing lesions in many patients. If you've got chemocystitis, that's a chemical irritating your body. It has nothing to do with mind body. If you've got estrogen atrophy, that's because your bladder is more vulnerable because you've gotten older and you've lost estrogen, or you're on birth control or taking Lupron. Pelvic floor injuries are the number one cause of IC symptoms. Again, that's not mind body syndrome. That's actually a physical injury to the muscles that have made them tight, that have put you into a state of ischemia. Our therapy is to reverse that ischemia by restoring blood supply, by relaxing those muscles. Pudendal neuralgia is, again, tight muscle squeezing nerves. But our last subtype, the widespread pain, that's where we start looking at central sensitization and the state of the central nervous system. And what our research has found is that patients who have widespread pain have a brain that is stuck in fight or flight. That 24 hours a day, 7 days a week, their brain thinks their life is at stake. That's not normal. That's abnormal. Normally, fight or flight is very short term. If you open up your front door and see a tiger, of course you're going to go into fight or flight. But we don't have to run from the tiger anymore. We shut the door, we call the authorities, they come out, they trank the tiger, they take the tiger away. The threat is now gone. And that's when fight or flight turns off and the parasympathetic nervous system retakes control of the brain, and it calms everything down. It lowers your heart rate, it lowers your blood pressure, it relaxes your muscles. So fight or flight was never intended to be 24/7. Fight or flight was only intended for when your life is generally at stake. What the research found is patients with widespread pain are literally stuck in fight or flight all day, every day. So, how do we know that? Well, they tend to have multiple pain conditions. They have very sensitive skin. They have a wicked sense of smell. And they struggle with anxiety and catastrophic thinking. And again, I was in this group. So we're the no people. Hey, Jill, you want to take it? No. Would you like to go to the movie? No. Would you like to go out to dinner? No. For years. Every single invitation I got, I said no. I wanted to do all of those things. But why did my brain say no? Because my brain was in fight or flight. My brain was trying to protect me by keeping me home. And that's where mind-body medicine rocks. Because when we get that brain out of fight or flight using some very basic mind-body medicine techniques to get the sympathetic nervous system to shut down, we can calm fight or flight, we can bring down the adrenaline overload, and we can calm all the pain throughout the body. So mind-body syndrome, the way you say it, implies that this is mental illness. This is not mental illness. This is a direct physical injury to the nerves. We call it a central nervous system maladaptation, and that's from the International Pelvic Pain Society conference that I was at 2 years ago. Hi, Boria. Loria says, nope, not a redhead. Turns out Ehlers-Danlos syndrome runs on your father's side of the family. and that has put your symptoms together, including POTS, MCAs, and trauma. Ah, Marlia said, I realized D-mannose is helpful to grab E. coli from the bladder wall, but also see many people feel that it helps your IC feel better and less irritated. So is there anything beneficial from D-mannose for bladder irritation besides UTI? No, not that I know of. No. And what the research shows is that proanthocyanidins, PACs, are more effective than D-mannose at preventing UTI. Remember that there is a very high placebo rate in the IC patient population, but that's common with several. And again, that's due right back to phenotyping, these different types of IC, these different groups of IC patients. Also remember too that there are companies selling D-mannose who they have one goal, to get you to buy it, and so they start drawing all these connections between mannose and all these bladder diseases, and it's like, no, no. Sue said, I finally have properly diagnosed pelvic floor dysfunction from multiple different things, but when I was menstruating, the first 3 or 4 days before my period would be the worst, worse than the day it started. It was instant relief, not exactly sure why, but instant relief. Interesting. Betsa said, I will ask. I did a transvaginal ultrasound. Everything's okay, except they couldn't see my left ovary. Okay. Hi, Deidre. Yeah, I'm okay. I'm not 100%. I'm like 80%. I've been kind of down for a day. But I have moments when, I just think we all have to get over the emotional trauma of all sorts of stuff. I feel traumatized from my surgery. Sherry said, my pelvic flow got messed up, recumbent, but okay. I don't know what you mean by there. Edna says, I'm in the worst pain right now. You're describing me. I'm in dire need of help. Okay, Edna. So when is your pain the worst? Before you pee or after you're done peeing? Tell us, when is your pain the worst? Before you urinate or after you're done urinating? Let's see if we can phenotype your pain right now. Now, if anybody wants to go into Zoom, we can always transition over into Zoom and just have normal conversation. I'm happy to do that too. Okay, so Edna, when is your pain the worst? When your bladder's very, very full? And do you feel better after you pee, or do you feel worse after you pee? That's the first question we ask to try to figure out what's going on. Thank you, honey. Thank you. And for anybody who finds these meetings helpful, please think about coming on over to the IC Network and joining our free newsletter. We also have memberships and things like that you can sign up for. We also have a really good shop where you can buy chair cushions and heating pads and some of our best supplements. Okay, so Edna, when is your pain the worst? Before you pee or after you're done peeing? I think she's on a very slow internet connection. Oh, stretch break, stretch break. Well, Edna is not answering, but that's okay. Edna, if you want to talk, I'm happy to talk with you by phone. We can always do that. Gina says, I always have microscopic hematuria in your urine after a urine culture. It is always present even when I'm in remission. My doctor never explains why is my bladder wall bleeding. Honey, so do I. I've always had microscopic blood in my urine. Especially before, I haven't had my urine checked now. Well, no, I was at the emergency room. Did they? No, they didn't check it. They had me pee in a cup, but they left it by my bed. Yeah, they did. They didn't check it the last time I was at the ER. Okay, for my gallbladder. So if you were peeing red blood or your urine was pink, then you're definitely bleeding. I consider that urgent. And that to me is a visit to urgent care. And if you're peeing bright red blood, then that's a visit to the emergency room. That is absolutely not normal. We need to figure out what the hell is bleeding in there. But microscopic blood is different because um let's say that you are an estrogen atrophy patient. Okay, so your bladder wall is thinner, you don't have that nice thick mucosal barrier anymore. And let's say you do that 1 cup of coffee every morning. Nobody can tell you to stop. You're going to do that 1 cup of coffee every morning. Well, the challenge is that 1 cup of coffee in the morning is irritating your bladder, your now thinner bladder wall. It is irritating it. So the question then is, how does the bladder respond to that irritation? Well, it's fascinating because if urine gets into the bladder wall, then your immune system kicks in. And so the cells of the bladder wall are not passive cells. They communicate. They can cry out, "Help, help, I need help. Something's here that shouldn't be here." And that mobilizes the immune system to send your body's fighters to the area, your white blood cells. So white blood cells come surging to your bladder, but they're in the blood vessels. But the urine isn't in the blood vessel. The urine's actually in the physical cell. And so what happens is as the white blood cells swarm to your bladder wall, your capillaries open and release them so that they can get into the tissue and kill whatever's going on there. And of course, it can't kill diet soda or coffee. It's wired to kill infection, but it's the same process. So when these capillaries open to release the white blood cells, it also releases a tiny bit of red blood cells. And that's the hematuria. So generally, hematuria is nothing that anybody worries about. Normally, a doctor, especially if you were a smoker, if you had consistent hematuria, they might send your urine out for a urine cytology test just to check for bladder cancer, because smoking is the #1 cause of bladder cancer. So I had a urine cytology test in my first year, which of course is negative. There's no association between IC and bladder cancer. Don't worry about that. The challenge is, they have to do a proper workup. And if you had visible blood, they're absolutely going to check for bladder cancer. But our AUA guidelines have taken a stronger step in the last revision last year, and they want doctors to be a little bit more aggressive and assertive in ruling out bladder cancer for patients who have blood in their urine. And so, but in general, the microscopic blood is not something that they worry about. It's the visible blood that they're going to worry about. So it's not that your bladder is bleeding, it's that your bladder is irritated, and that's cause white blood cells to swarm to your bladder wall, and the blood vessels open to release the white blood cells, which then releases that little tiny bit of blood. I'm wearing my Auntie Mister's ring. See that ring right there? I inherited this ring. Auntie Mister was my mother's aunt. My mother's aunt, I have an award she got during World War II from the American Red Cross. I actually have it hanging up in the hallway. She fell in love and was in a relationship with a man who was very, very unhappily married. They had split for decades. They weren't divorced, but they had split. And World War II and then the 1950s, they were together, hoping that they would be able to get married. But in the end, he decided that the church would not support a divorce and broke her heart. And one of the ways he tried to regain her was by giving her this ring. This was her engagement ring, but it never happened. And she remained single her entire life because she was in love with him. So this came to me. So I feel her. I feel her, and I feel my mom all the time. Anne said, "Is there a concern for a man to have hematuria?" Absolutely. Anybody who's bleeding from their bladder, whether it's a man or a woman, needs to be investigated. I've worked with a number of patients who have had bladder cancer, including a man that I worked with for several years who had invented a product that we used to sell, and I'm not going to say the name of it, but he ended up having a bladder cancer, and they removed his bladder. But he waited way too long, and the cancer had spread, and he did die of that cancer. So Sherry says, "What does it mean if you hurt more after you pee?" That means that it's your muscles that are in all likelihood causing your symptoms, and that your bladder wall's healthy. If you have pain as your bladder fills with urine, that means that urine is irritating your bladder and or going into any Hunner's lesions. So the fuller you get, the more urine irritates the bladder wall. And then finally, when your bladder is really, really full, you're crying in pain, you pee, and all the pain goes away because urine is no longer irritating your bladder wall. So what that tells me, Sherry, is that you have a healthy bladder, that in fact, that pain after urination is probably due to your muscles. The other thing is, and you say it never hurt when my bladder fills, always after. So that alone excludes you from the old way that we used to diagnose IC, because IC was originally diagnosed with pain on bladder fill relieved by urination. So the good news here is that you've got a good, healthy bladder. Now what we've got to figure out is what's causing that pain if it's not your bladder wall. And so, Sherry, would you, for example, be straining when you're urinating? Can you start your urine stream right away, or are you hesitating 5, 10, 15 seconds before you can relax enough to release urine? Or are you straining to push out urine? Both of those are signs that we're dealing with dysfunctional muscles. You're welcome, honey. You're welcome. Sherry said, "I feel it's pelvic floor driven. Yes, there's hesitation." So if there's hesitation, it's pelvic floor driven. So have you gone to physical therapy? Have you had a pelvic floor assessment? I'm drinking rooibos tea. You've been to physical therapy. Okay, so Sherry, what did they find during your pelvic floor assessment at that first appointment? Yes, and you're doing the wand several times a week. Okay. So Andrea says she loves that tea, Cole. I do too. So Sherry, when you're using your wand, are you finding, so when I'm using my wand, I'm always looking for any muscle groups that hurt. And if I find any muscle groups that are tight and or hurt, that's where I focus my wand work as I try to get that muscle to relax and release. And for me, it's usually on my left side. Oh, there's a squirrel right there. Carol says, "Thank you for the pudendal nerve information. I am seeing a pelvic floor therapist and will relay the information as well as checking the IC website. It's suggested. It has always felt like a UTI with a pulsing feeling in the vulva." Yeah, but UTIs don't cause a pulsing feeling in the vulva. Pudendal neuralgia causes pulsing feeling in the vulva. And you know what? Hold on a sec. I think I have here. Hold on. Okay. So, so, um, so Carol, I had something really interesting happen about 6, 7 years ago. I started feeling pinpricks, a pinpricking sensation at my pubic hairline right in front. You know that feeling you get if you pull on a pubic hair or you get a pubic hair stuck in a zipper and it's like a little tug? I started getting that. And interestingly, throughout the years, I've had that every now and then, but it was very, very distinct and intense. And it's like, so, I go to the bathroom, I take a look at my pubic hair, see if anything's pulled, you know, anything's weird. Sometimes if you trim your pubic hair at the wrong, if you do that and you trim it too short, then that's a whole nother can of worms. It's a whole nother discussion. Anyway, I don't do that, but I check for that. Okay. So over a period of a week, that sensation. So this is underneath the skin, right? So I felt pinpricks like right up here. And then over a period of a week, it went all the way down to my rectum. And I would get a pinprick on the left side, then a pinprick on the right side. Sometimes it would be on the front, sometimes it would be in the back. I'd never had anything like that before. It wasn't itching, it wasn't yeast. It felt like I was being poked by a pin. I mean, it was intense. So I go to an urgent appointment at my gynecologist. It's an older guy. He goes, it's yeast. You're bright red. And he gave me yeast meds. Didn't work. It just got worse. Poking all the time. Then I go to my regular gynecologist and she goes, it's eczema. It's eczema. Yeah, you're really, really red down here. It's got to be eczema. She put me on steroids for 6 weeks. It did nothing. Just got worse and worse and worse. And she's much younger than I am, really didn't respect me that much. And so I said, listen, I want to talk to the pelvic pain doc. I want a referral to the pelvic pain specialist because I'm in Kaiser Permanente. So I have a phone appointment with the pelvic pain specialist. And she goes, Jill, don't you know what this is? And I'm like, no. She goes, honey, it's pudendal neuralgia. Your muscles are tight again. Your muscles are squeezing the nerves again. So what she said, I need you to go back to physical therapy because you have a history of pelvic floor dysfunction. Something has happened and your muscles are locking down really tight again. So we need you to go back to physical therapy. And she gave me a topical jelly of estrogen and lidocaine to calm the nerves right on my skin. And so I go back to physical therapy 2 weeks later, and my physical therapist goes, wow, you are really tight, Jill. And I'm like, wow, I had no idea. I had no idea that pudendal neuralgia could manifest as pinpricks in your pubic hairline, not even on the inside of your crotch, but on the outside of your crotch. So if you look at this, well, I've got a lot of pictures. This kind of relates. This is a picture of dermatomes. So if you have a ruptured disc in your back, depending upon which disc is ruptured, that will tell us where you will feel that. And so a dermatome is basically a mapping of the nerve. And if you look really close here, you can see the nerves S3, S4, S5, which basically, and C1, these are the nerves right in your butt cheek and right on the upper inside of your thigh. And then there are other pictures which look from at your crotch area, and it will show you exactly where those nerves are distributed. So That fluttering you're feeling by your urethra is not a UTI. That is a nerve that is being compressed. That pulsing feeling in your vulva. That is a nerve that's being compressed, Carol. And is microscopic blood in men any concern? Absolutely. I answered that. Are you not asking that question? I'm not. Are you trying to ask a different question than that? Are you talking about men? Pamela says, I'm 72 years old. I've been in estrogen atrophy, been diagnosed by a urologist to IC in 2013. That would have been when you were 61 years old. I have sudden severe burning pain in my bladder and my urethra with a sense of urgency. After I urinate, the pain goes away. Will estrogen cream help you? Yes, it will. Yes, it will. You are an estrogen atrophy patient. Your symptoms started when you were in your early 60s. So you have to understand that the way the bladder protects itself is with a really thick coating of mucus. Your bladder's wet on the inside, just like your mouth is wet on the inside. Your urethra is wet on the inside, just like your vagina and your vulva are. They're mucous membrane organs. And that wetness, that mucus, plays a really important role in the structural integrity of that skin. Unfortunately, mucus production is estrogen dependent. So when you're younger and have lots of estrogen, you have a lot of mucus. But woman, once you hit your 50s and 60s, your estrogen levels drop, your skin started getting thinner, and the urethral pain, that's what I had first. I had the urethral pain after menopause before I had any other pain associated with it, because the urethra is kind of the canary in the coal mine when it comes to estrogen atrophy. And so that sense of burning can literally be urine, the chemicals in your urine irritating the cells of your urethra and bladder because you just don't have the mucus anymore. So this is called the genitourinary syndrome of menopause. I have a website I built on it, bladderhealth.org, bladderhealth.org. Go on over to that. And yes, estrogen cream will give that skin what it needs to produce mucus. And generally for urethral pain, they'll have you rub a pea-sized drop right into the entrance of the urethra. That's what they had me do. And it took, I had urethra, listen, my IC self-help skills are excellent. They are excellent. I know what I'm doing. And yet when I was 51 or 52, somewhere in there, I had this urethral pain emerge that I'd never had before. And for 3 weeks, I threw everything I knew at this urethral pain. Nothing worked. Nothing worked. And I finally, out of total exasperation and frustration, went to my urologist, put me up on the table in stirrups. He takes one look at me and he goes, Jill. And I'm like, what? What did I do? He goes, didn't you use the estrogen cream I prescribed for you last year? And I went, no. And he said, why? And I said, because in my brain, I'm 25 years old and I can't possibly have an age-related issue, which is exactly how I felt at the time. I still feel that way. And he laughed and he goes, I was trying to prevent this from happening because I could see your skin starting to get drier and drier and drier last year. That's why I gave you the estrogen cream. He re-prescribed it. He explained the canary in the coal mine with the urethra, and he had me rub a pea-sized drop into the entrance of my urethra, and within 2 weeks, it all went away. And if I forget to use my estrogen cream for 2 weeks, it comes right back. So I'm very, very invested in keeping my skin as healthy as I can. Is it a prescription? It is a prescription. Where does it get applied? You can do it internally. You can do it externally. It's really very little. You might do it 2 or 3 times a week. It's not like yeast meds where you have a big applicator that's full. Like literally, it's only like this amount in an applicator or on your skin. So it's no biggie. Just be prepared for the fact that you might be very, very dry down there. So the first couple of times you use your estrogen cream, it might burn. It might burn more. But that just means your skin is very, very dry. And every subsequent time you use it, Your skin absorbs that estrogen, produces mucus, the burning gets better and better and better. So you have to ride yourself through the first week or two of any extra burning that might happen with the estrogen cream. It will go away. It normally goes away. Julie says, I have a slip disc in my lower back and I feel it. I feel it at times in my orgasmic area and other vaginal areas. Yeah. And for me, I have L4, L5 ruptured, and I feel that in my right thigh. And if we have the dermatome map, here is L4 and L5. And that's where I feel my pain. Whoops. So there's L4 going from the outside across the thigh, and L5 is on the outside. A dermatome map. Marlia says, I'm so sensitive to a lot of things. I shave my legs, skin gets beet red, wear wool socks, skin gets beet red, eat tomatoes, bladder burns. My question is, I know my bladder is sensitive too. What would be the best thing for being sensitive? Bladder rest, P or a PEA? I think PEA, bladder builder or PEA. The PEA is believed to act directly on the nerves, calming the nerves down. And so the bladder builder has a chondroitin in it for the bladder wall combined with the PEA and some other stuff. But if we're just focusing on nerves, the PEA, in my opinion. Julie says, and the gynecologist just diagnosed vaginal atrophy. That cream for sure calms it down. Exactly. So vaginal atrophy, if you have vaginal atrophy, you have genitourinary syndrome of menopause. Thank you, Julie. It's through personal experience. Julie said, oh yeah, I stopped the estrogen cream. It burned terrible, nausea, really sick. Maybe I need to try it again. I hope it would subside. Well, we have to figure that out. I mean, you have to get back to your gynecologist and say it may be that there was a filler in the estrogen cream that irritated you. Premarin, for example, is not usually well tolerated. But if you get a preservative-free formula of estrogen cream, which is what I do, then you don't get a lot of that extraneous burning. So it's the brand names like Premarin that tend to have more preservatives in it to expand shelf life. And it's that alcohol and the preservatives which can cause more burning. Whereas if you get a compounded estrogen cream, it tends to get better. Hello, Shirley. I love your name, Shirley, because I had a beloved Aunt Shirley who was such a joy in my life in my childhood. Aunt Shirley was just the best. Julie says, okay, yes, preservative-free, and it was Premarin. Exactly. So Premarin is notorious for causing a lot of extra burning. I had a book on my shelf. Oh, what was the name of it? It's out in my garage now. That had a whole chapter, or it had a whole section on Premarin and how it caused a lot of extra vulvar irritation and burning. It's just the shelf life. I mean, it's just all the extra preservatives that they have to put into it, if I remember correctly. Would anybody like to go into Zoom and have a chat in Zoom? We can easily do that. You're welcome, Julie. Julie says, thanks. You're welcome. What blows me away, because you got to understand that from the time I was 33 until I was like 52, I thought I had an incurable bladder disease. And I was very diet sensitive. And of course, now we know why patients who are muscle driven become diet sensitive, because tight muscles restrict blood supply to the bladder wall, and the bladder wall can't be healthy if it doesn't have good blood supply, if it doesn't have good oxygenation and nutrition. And so, of course, patients with really, really tight muscles are going to end up with a more fragile bladder wall. And for those patients, bladder treatments don't work. because bladder don't treatments don't fix the underlying problem, which is ischemia caused by tight pelvic floor muscle. Marlia, it's right on the back here, icnetwork.org. icnetwork.org. So anyway, I literally from 33 until my mid 50s, I followed the diet perfectly. And I have always stayed away. I might have one soda every 5 years. I literally, my diet was so pristine that I didn't even, because I guess because of the IBS when I was in my 20s, I'm not one of those people who likes to go out to eat because I didn't like to experiment with food because I was so food sensitive. Anyway, so, my lifestyle was no citrus, no tomato, nothing, no, nothing, just to be, as safe as I could possibly be because I did not want to be in pain. And then I got COVID last May at the hospital when my parents passed. We all got COVID. We were all exposed to COVID at the hospital for the 5 days that we were there doing, their end of life. And the last time I was with my mom while she was alive, I started coughing so badly. It's in the first 5 minutes that I was retching. Like I literally had to run to the bathroom. I was retching. I could barely breathe. It was such a violent cough. So I just I don't go back to be with her because I literally was barely breathing. I ran out of the hospital, drive home, and I'm going, hot lemonade, hot lemonade. I will risk a bladder flare to stop this violent cough from COVID. So I stop at the store, I buy lemonade, I buy honey, I heat it up in the microwave, and I drink it, and it works very well. But I was stunned that it didn't flare me at all. I hadn't had lemonade since I was 33. I remember once I had a little bit of lime juice and I had a terrible flare in my 30s. And so what did that tell me? So I've been drinking lemonade every day ever since. I do hot lemonade, I do cold, I dilute it. I'm not an idiot. I'm not going to drink super strong lemonade. And I made minestrone soup last night with tomato sauce and tomatoes. No flare. I didn't have that for years. So what does that tell me? What that really proved to me is that all the muscle work I did worked. That I got my muscles to relax and release. It restored blood supply. And my bladder wall actually healed once it got a good blood supply. And so that's what I wish for you guys. It's crazy. I still think it's bonky that I can drink lemonade and I haven't flared once from it. Gina says, homemade black unsweetened iced tea too acidic for your bladder. I was drinking it every day, which could have made me come out of my remission. Yes, I would consider it too acidic, but also the caffeine. The caffeine from black tea also would have triggered the nerves, which would have made you pee more. And Gina, remember, sometimes it's an accident of timing. You might have been able to tolerate the black tea when you were younger, but now you're older and you're probably in some estrogen atrophy, which means your bladder wall's more vulnerable, and the black tea just got you. The black tea just irritated your bladder over time because your bladder wall can't defend itself. So are you better now? Do you feel better now that you've stopped it? And green tea is worse than black tea, just so you know. Green tea is devastating. Rooibos tea, a brown rooibos green tea is the one to go with. And if you're looking for a coffee option, look for Dandy Blend Herbal Coffee. It's so incredibly good. Julie says, that was knowledge she was not aware of. Gina just turned 60. Girl, Welcome to the club. I'm 63. That's so weird. It's so weird. It's so weird that you're still the girl you were when you were a kid inside. It's just you have an older body, but your heart and your soul are still young. I think the hardest part of getting older is that now we're starting to lose our friends and our family members. That's what I struggle with the most right now. Gina says, I'm getting better. It's been 5 months and you still have bladder issues. So, Gina, are you using any estrogen? Are you using any topical estrogen to work on your skin, to get your skin healthy? Marlia, bladderhealth.org. Bladder health, like healthy, except no Y. Bladderhealth.org is a website that I just built on estrogen atrophy. We've got a lot of things planned for this year with estrogen atrophy patients. It was the theme of IC Awareness Month press release last year. It really infuriates me that millions of women have been told that they have an incurable bladder disease when they don't have a disease at all. It's just estrogen atrophy. And many of them are prescribed estrogen, but they don't know why and they don't use it. So they just keep thinking that they have infection after infection or they've got an incurable disease. And it's when somebody actually explains the anatomy and how that is affected as they get older, that's when the light bulb turns on. Like the single most important thing for these patients is that topical estrogen to improve the skin. As we improve the skin gets stronger and more resistant to irritation. Julie said, did you hear about a drop bowel that presses on the back of the vagina? I've been experiencing that. My gynecologist will not touch in surgery. She's looking for a surgeon. Interesting. There's ligaments that hold the uterus in place. I could see if you'd had a hysterectomy that your bowel could fall into the area where your uterus used to be. It sounds challenging, Julie. I think I can't imagine what that must feel like. Marlia says, thank you. You're so helpful. You're very welcome. Shirley says, Jill, every time I hold my urine afterwards I have pain and pressure. I got diagnosed 3 years ago. I tried Botox 3 times. It did not work for me anymore. My urologist prescribed Gentesa instead of oxybutynin. So Shirley, let's just be really, really clear here. When is your pain the worst? As your bladder's filling with urine, and do you feel better after you pee? Or do you feel worse after you pee? When is it the worst? When you're full or after you're done? Lori said, it's been 3 months since it burns after I urinate. It is getting better slowly. Tell me this is normal for IT. It depends upon where the burning is, hon. So what you just said, it's been 3 months and it burns after you urinate. It is getting better slowly. Where is it burning? Be specific. Is it burning on your skin? Like literally as you're peeing, do you feel like it's burning your vulva? We call that urine burn. So is it burning on the vulva after you urinate or as you're urinating? If yes, that is completely normal for estrogen atrophy. That is one of the first signs that your skin is getting drier because it doesn't have estrogen. And that's not Hunter's lesions at all. Burning after urination either points to a problem with your skin or points to a problem with your muscles. If you had Hunter's lesions, your worst pain would be when your bladder was very full and you would feel better after you urinated. Julie says, yes, she had a vaginal hysterectomy. It's painful, and I have to use digits to assist BM. It's only become a problem as I aged around 60. So I also had a vaginal hysterectomy 6 years ago, and I feel your pain and frustration, my dear. When vaginal hysterectomy can injure pelvic floor muscles. If those pelvic floor muscles get tight, it's going to be hard to have a bowel movement. And so I would want to know also what the health of your pelvic floor is. I had 10 months of pelvic floor spasms after my hysterectomy. And I had to go into another round of physical therapy to work on it. And as long as I keep those muscles happy, I'm good. But if those muscles get really, really irritated and they get super tight, I'm going to start having problems again. Okay, Shirley says, you have pain when you're full and afterwards. But when is it the worst? When is it the worst? Is it worse before you pee or after you're done peeing? It's And for those of you on YouTube, you have a 3-second delay between the times you can write. It's worse afterwards. Okay, so where specifically is it worse? Where specifically is it burning? Is it burning on your skin on the outside? So can you touch where it burns with your finger? Or is it burning on the inside? This is important. Lori says, after I empty in my urethra, you have the sensation for about 20 minutes. So that could very easily just be estrogen atrophy, hon. Got to get that skin in your urethra better. Okay, Shirley says it's pain and pressure on the inside. Shirley, how old are you? You're 61. Okay. And how old were you when this all began for you? Is this new? This bladder thing new, or have you had this for years? Julie says, okay, so Julie, I've been scheduled for pelvic floor therapy, but it was so painful they let me stop. Okay, so if a physical therapist touches something and it causes pain, that's what I call your hallelujah moment. And your immediate question, Julie, is what are you touching? What are you touching? That's often where we find the muscle issues. Lori, for the estrogen atrophy, it's going to be an OBGYN. She wants to know who would help, an OBGYN or urologist. I would do an OBGYN to look at the quality and health of your skin down there. Okay, so getting back to Shirley on YouTube, you were 57. So it started about 4 years ago. So again, Shirley, that puts you first in the estrogen atrophy group. That the reason why your bladder is struggling is because your estrogen levels finally dropped to the point where it could not produce the estrogen where it did not have enough estrogen to produce the mucus, which normally protects the bladder and the urethra and the vulva and the vagina. So we call this estrogen atrophy or the genitourinary syndrome of menopause. So that's going to affect your skin on the outside, but it's also going to affect your skin on the inside. It's going to affect your urethra. It's going to affect your bladder. One of the consistent things that we see in estrogen atrophy that leaves women very, very confused is what I call urine burn, where your urine feels really, really hot, like it's burning you. And your urine really is not hot. It just means that the skin that the urine is touching is getting dry and more sensitive. So I would, number one, want somebody to look at your skin down there to see where you are with respect to dryness. At your age, 61, you're dry. You're dry in your early 50s. That's you can start that drying out process in your 40s with perimenopause. So concept number one is how healthy is your skin? And then concept number two is how healthy is your muscles? Are your muscles down there? Because if your muscles are tight, and that's what happens when you're in pain. When you're in pain, your muscles get tight to protect you from the pain. If your muscles are tight, we also want to maybe do some physical therapy to get those muscles to relax and release. So that pain on the inside can be driven by your skin, but it can also be driven by tight muscles. That pressure is usually associated with tight muscles. Another thing that happens as we get older is our muscles just get weaker. And as they get weaker, things start to go where they're not supposed to go. People can get prolapses where the bladder starts to fall, or the vagina starts to fall, or the rectum starts to push into the vagina. You can get a rectocele or a cystocele. And so we would want a gynecologist really to look at your skin, but also just look at you down there and do a pelvic exam, and let's just see if your muscles are tight. And if they are, then you need to go to physical therapy. And Botox is not she said she did Botox 3 times. It doesn't work for you anymore. Botox works by silencing nerves. So they can inject Botox directly into the bladder wall, or they can inject Botox into tight muscles. But it's not fixing anything. It's just calming that nerve down or silencing that nerve for a period of time. But the Botox will always wear off. And when it wears off, you're back to a funky nerve. So what we need to do is understand, why is that nerve compromised in the first place? It's going to be compromised if you have dry skin, and it's going to be compromised if you have tight muscles. And gosh, if you had any falls or any history of athletics, tailbone injuries, it can, sometimes it's multiple things that are just triggering all of this. But you have a pelvic pain disorder for which there are many potential causes. Lori says, silly question. What does estrogen do to help your skin down there? Well, you know what happens if you put a raisin in a glass of water? If you put a raisin in a glass of water, that raisin plumps up because it absorbs the water, and it comes closer to looking like a normal grape. Well, that's what estrogen does. When you put estrogen on these dry skin cells, the skin cells immediately draw the estrogen in, and they start to plump up and they start to produce mucus. Literally the most natural thing you can do. People always say, I want to go natural. The most natural thing you can do to restore bladder health and your skin health down there is estrogen. Because when you give that skin estrogen, it produces your own natural mucus. So estrogen helps to keep skin healthy. Make sense? It is an important hormone that influences a lot of different things throughout the body. And in the skin, for example, it is used to produce mucus. All right, guys. Well, I think we're I think we've come to the end. Your questions have slowed down. So I think we've been going for 2.5 hours now. That's farther than I thought I'd go because I wasn't feeling particularly bright and cheery this morning. I want to thank you for coming to this meeting, and please let your friends know that if they have IC and pelvic pain, we're here for them. They're welcome to call. I talk with patients almost every day. We have a fantastic website that's rated the best on the web by Harvard Children's Hospital and by the University of London. I curate all that information, and I am a support group leader first and foremost. I'm happy to be here. Shirley said, okay, I understand. Yes, if you've fallen down some stairs about 5 years ago, it was a really bad fall. Shirley, you'd be amazed by the number of patients whose symptoms began after they fall downstairs. It's a very common injury. So the fact that you had that injury tells me you really, really need to go to physical therapy, a proper pelvic floor physical therapist, to see if that injury left a legacy of tight muscles. It's very, very common. And so the best place to find a physical therapist is at a website, pelvicrehab.com. Pelvic and then rehab, short for rehabilitation. Pelvicrehab.com. That is a list of 10,000 physical therapists around the United States, Canada, that have been trained in pelvic floor work. So you need to go have a pelvic floor assessment. And please know that this is not Kegels. You cannot do this at home with Kegels. Kegels will make it worse. Because Kegels are designed to tighten muscles that are weak. But if you already have tight muscles and you do Kegels, you're just going to make them tighter and tighter and tighter. So it's very important that I just put in our master class, you're on YouTube right now. So if you go back to our channel on YouTube, you can watch the class I just uploaded last night on pelvic floor physical therapy. So go ahead and watch that too. And I think that will really help Shirley. All right, guys, I think we'll call it here. Be well. Hopefully I'll see you next week. Knock on wood. Let's just hope that the world remains sane and that we don't have any more natural disasters. Life. All right, guys, I'll see you later. All right. All right, YouTube. I'll see you guys later. Have a good one.